In terms of TIAs, TIAs are sometimes referred to as missed or mini strokes. They reflect transient ischemia, technically less than 24 hours, though most TIAs are only several minutes. The typical TIA story is 5 to 10 minutes when symptoms resolve. Longer than that, there's typically findings of a stroke on MRI scan. In terms of screening, a patient who presents with a TIA, screening for carotid stenosis is recommended for all patients with TIA and stroke. Risk factors for TIA are the same as those for stroke, including hypertension, diabetes, hyperlipidemia, obstructive sleep apnea, smoking, and excessive alcohol use. In terms of treatment, there is a specific number to know here. A patient who's had a TIA should undergo carotid ultrasound. If the level of stenosis is 70 to 99%, that patient would likely benefit from a carotid endarterectomy. And that is a specific number that might be worth knowing. 70 to 99% is the indication. Less than 70%, a surgery is not indicated. Completely occluded, surgery is not indicated. Patients who've had TIAs may benefit from dual antiplatelet therapy with aspirin and clopidogrel for about 21 days, and then aspirin or clopidogrel as a monotherapy. I want you to contrast that with this case. A 27-year-old female presents to the emergency room at 7:23 a.m. after waking up with right monocular painful vision loss. Patient describes the symptoms as being like looking through a screen. Vision from the left eye is normal. There is a difference in color perception between the right and left eye, with the right being less red. Her right pupil constricts when light is shined into the left eye, but dilates when light is shined directly into the right eye. A non-contrast head CT is normal, as are all labs. What's the most appropriate diagnostic test of the available options? An EEG, bilateral carotid duplex, 4-vessel conventional angiogram, ocular coherence tomography, or an MRI scan of the optic nerve with and without contrast. If you look, there are a few differences in this case. This patient has painful monocular vision loss that is persisting with color perception, particularly washing out of reds, and has an afferent pupillar defect. So of the available options, the best would be an MRI scan of the optic nerve with and without contrast, looking for a demyelinating lesion. So this patient's symptoms are highly consistent with optic neuritis, inflammation of the optic nerve. Of the other options, OCT is commonly used now in neurology to look for evidence of multiple sclerosis, though it's not typically the first test for optic neuritis and doesn't evaluate more thoroughly for multiple sclerosis. This patient's symptoms are not consistent with the TIA. They last longer. They're much more consistent with an inflammatory condition, so carotid ultrasound is unnecessary. EEG and conventional angiogram would also be unnecessary, as the patient has an inflammatory condition, not a structural issue or a paroxysmal issue. For multiple sclerosis, optic neuritis is one of the most common presenting features. It is occurring in about 10 to 20% of patients with multiple sclerosis and is often the initial symptom that develops for patients when they're brought to attention. So for testing, optic neuritis is a clinical diagnosis, but an MRI scan with and without contrast can help confirm the diagnosis by showing evidence of inflammation of the optic nerve and screen for lesions that are disseminated in space and time to make the larger diagnosis of multiple sclerosis. Optic neuritis isn't pathognomonic for multiple sclerosis, but optic neuritis is a common presenting feature of MS. Patients who present with optic neuritis, lumbar punctures are not required, but they are commonly done looking for the presence of oligoclonal bands or other markers. In terms of treatment for optic neuritis, high-dose intravenous methylprednisolone is recommended, usually at 1 gram a day for 3 to 5 days. That's considered first-line therapy. There are other treatment options for optic neuritis, but the recommendation is high-dose intravenous methylprednisolone. For the treatment of multiple sclerosis, there are multiple options. I think that will be beyond the scope of what this test would ask. The only important take-home point I would have is MS has become a highly treatable condition with over 20 FDA-approved medications for its treatment. I want to highlight one thing. This patient does have an afferent pupillar defect or Marcus Gunn pupil. On the content outline is the ability to recognize an afferent pupillar defect. And what will occur if you shine light into the good eye, light goes back along the optic nerve, wraps around, and comes forward on the third nerve, so both pupils will constrict. If you shine light into the bad eye, light can't go back along the optic nerve, the signal gets blocked. As a result, the pupils will dilate. That's your afferent pupillar defect with your swinging torch test or Marcus Gunn pupil.